Hi everyone, my name is Irene Huffnagel. I'm a pediatrician in training and a postdoctoral researcher in the ALD team in Amsterdam, the Netherlands. And today I will be discussing some of our work on spinal cord disease in adrenal leukodystrophy and clinical trial readiness. Spinal cord disease is the main cause of disability in both male and female patients with ALD. And the graph on the left shows the percentage affected patients versus age in men. And as you can see, spinal cord disease rarely manifests before early 20s, but the gross majority is affected by the age of 50. The graph on the right shows the percentage affected, or what we call symptomatic patients, versus age in women. And age of onset is slightly higher in women. For both men and women, there is an enormous variation in age of onset. There is still no treatment for spinal cord disease, although there are currently some therapies under preclinical or clinical investigation. Why is it taking so long? Over the past decades, one of the problems has been that measuring progression of spinal cord disease is a challenge. Physicians have been very good at detecting the presence of spinal cord disease with a thorough history and neurological exam. But if the spinal cord disease has progressed after 1 year and how much the disease has progressed exactly, that is a lot harder. And that is a problem, because if you have an interesting new therapy for spinal cord disease, how are we going to prove that it is effective in a trial if you cannot measure progression of spinal cord disease? That is why our group focuses on the evaluation of potential outcome measures that could be used to measure spinal cord disease progression in clinical trials. So at first, we evaluated various clinical measures, and clinical measures are outcome measures that, for instance, use reported symptoms, a physical exam, or tests that include functionalities that patients use in daily life, like walking. And in this specific study, we prospectively followed adult men for 2 years. And we demonstrated that 4 clinical measures can detect progression of spinal cord disease after 1 or 2 years. And the first one, the EDSS, was originally actually designed to assess disability in MS patients, but it's also widely used in ALD. And it includes symptoms and a physical exam, and the score ranges from 0 to 10, with a higher score indicating a higher degree of impairment. And during follow-up, there was a small increase in the EDSS score, with an average change of 0.34 points. The second one, the SSPROM, is a score used for all kinds of patients with spinal cord disease and rates the degree of impairment. Like the EDSS, it also includes symptoms and a physical exam, and it ranges from 0 to 100, with a lower score indicating a higher degree of disability. Here, the average change was a decrease of almost 3 points. The timed up and go and the 6-minute walk tests are timed activities to assess walking function. In the timed up and go, the time is recorded that the patient needs to get up from an armchair, walk 3 meters, turn around, walk back, and sit down again. On average, the patients took about 1 second longer to perform the task after 2 years. The 6-minute walk test measures the maximum walking distance in 6 minutes. For this measure, we only had follow-up data after 1 year. For the other ones, it was 2 years. And you can see that on average, participants walked 20 meters less after 1 year. Besides these outcomes, we also looked at various questionnaires, or what we call patient-reported outcomes, in which patients have to score their own symptoms or disability. But none of these showed significant change during follow-up. Besides our study in adult men, we also evaluated disease progression in adult women in a follow-up study. After 8 years of follow-up, we determined that the EDSS, that was the measure that was initially designed for MS patients, showed a significant disease progression with an average of 0.08 points per year. So that's a lot less than we just saw in men. And although this is statistically significant when you test it, you should know that such a small change is generally not considered clinically relevant. And like in men, 2 of our patient-reported outcome measures, the questionnaires, did not change during 8 years of follow-up. So based on these 2 clinical studies, we can conclude that we can actually measure progression of spinal cord disease in adult men and women with ALD, but changes were small. So why did these outcome measures not perform better? What's the problem? Well, firstly, they're not specifically designed for the spinal cord disease in ALD. And second, measures that rely on history and neurological exam or walking function need a specific type of patients, because they need patients that are not asymptomatic, but they're also not too symptomatic. Because if you have an asymptomatic patient who remains asymptomatic during follow-up, no change will be detected on clinical measures. But if a patient is too symptomatic, he will not be able to participate in any timed walking activities. And that's what we call floor and ceiling effects. But taking all this into consideration, a relatively short clinical trial can be done in men, but you need a lot of patience. And for women, well, in theory, a trial can be done if you have a lot of time, but in reality, a trial of 8 years, that's not really feasible. So we need new alternative outcome measures that can measure the specific underlying pathology in ALD and are more sensitive to small changes in spinal cord disease. And considering the amount of patients we need for trials, we would increase the number of eligible patients drastically if we could include asymptomatic patients, patients in wheelchairs, and women. And for this, we evaluated several alternative outcome measures in our Dutch ALD cohort study, which includes over 100 Dutch boys, men, and women with ALD. So when looking for alternative outcome measures, MRI is an obvious choice if you want to detect the specific underlying disease pathology, as it can detect changes in the white matter of the brain and the spinal cord. So first we looked at a group of adult men with ALD to see if the shape of the spinal cord had changed due to the white matter disease. And here you see an MRI image of the neck region in image A, with the nose on the right side and the back side of the body on the left side. And images B through E are actually cross-sectional images of the same region. And B and D belong to a healthy control, and C and E belong to a symptomatic adult male patient. And if you look up at the close-ups of the spinal cord in the yellow boxes, you can see that the spinal cord of the patient actually does look different because it looks a lot thinner, but also flattened. So when you measure this flattening of the spinal cord, you can see in this figure with the degree of flattening on the y-axis and the different sections of the spinal cord in the neck on the x-axis, that in symptomatic patients, the gray line, the spinal cord is thinner in the entire neck region in comparison to asymptomatic patients, the red line, and controls, the blue line. From the graph, you can also see that there was no difference between asymptomatic patients and healthy controls. Okay, so the spinal cord looks different in symptomatic patients, but to be able to use the degree of flattening as an alternative outcome measure, the degree of flattening has to correlate well with the degree of spinal cord disease, which you can see from the outside. Otherwise, you don't know if it actually makes sense. And also, when the spinal cord progresses, so if somebody, if in a patient, the walking decreases, then the alternative measure should be able to detect this change. And indeed, for the spinal cord flattening, this correlated well to the clinical measures of spinal cord disease. But there was no change in flattening after 1 year follow-up, although the clinical measures did change. So this makes spinal cord flattening interesting as an outcome measure, but longer follow-up is needed and currently ongoing. Besides looking at the shape of the spinal cord, we also use MRI to look at specific properties of the white matter motor tracts in brain and spinal cord, which are involved in voluntary movement. And these tracts are colored in the left image. And this study also included adult male patients. The two graphs show two diffusion parameters in the different regions: the spinal cord, the brain total tract, and 5 separate segments in the brain. And you can see that for some of these, there is a clear difference in the diffusion parameters for controls, asymptomatic patients, and asymptomatic patients. Moreover, during 2-year follow-up, we detected only a small change in the clinical measures for spinal cord disease. One of those you can see on the right, the EDSS, and a slightly larger change in the diffusion measures in brain, which you can see in the left graph. And what is actually also very important is that when we only included asymptomatic patients, the diffusion parameters still significantly changed, while clinical measures did not. And this is really important because if you can measure disease progression in asymptomatic patients, there are a lot more eligible patients for trials. Besides studying MRIs, we also looked at the eye, or more specifically, the retina, with a technique called optical coherence tomography. And the retina is an essential part of the eye that enables vision. It receives light and converts this to a signal that can be processed by the brain. Optical coherence tomography is an imaging technique that enables precise imaging of the retina so we can measure the thickness of individual nerve layers within this retina. And all the different shades of gray you can see in this image actually belong to separate nerve layers. And we know from other neurodegenerative disorders like MS and ALS that a decay of the nervous system occurs simultaneously in the retina, and that the eye may therefore offer a window to the brain. As optical coherence tomography is also fast and non-invasive, it only costs a couple of minutes to make the scan. It's like you're getting some new glasses. We were very interested to see if the same association was present in ALD patients. And for our study, we focused on the top layers, which are colored in the close-up. So for this study, we included both men and women, and we started out by evaluating if there was a difference at all in the thickness of these retinal layers between patients and controls. Well, one of these layers, specifically the blue-colored one in the previous image, was a lot thinner in both male and female patients when compared to healthy controls. And in male patients, the degree of thinning correlated very well to the degree of clinical spinal cord disease. But in women, this correlation was less clear. The next step was to see if the thinning worsened in time, just like the spinal cord disease worsens in time. And we did this both in men and in women, but the follow-up time for women was a lot longer, as we saw at the beginning of this presentation that progression in women is a lot slower than in men. So the study in women is still ongoing, but these results are from our study in men. During 2-year follow-up, the neuroretinal thinning worsened significantly in all patients, which you can see in the green line, in comparison to healthy controls, the blue line. And when focusing on the symptomatic subgroup, the red line, the worsening was still significant. In the asymptomatic subgroup, which is not displayed separately in this graph, we saw a similar trend, but the group was too small to actually do any statistical tests. But overall, the degree of thinning correlated well to the change in clinical measures of spinal cord disease. Important side note is, however, we did notice that there was a relatively large loss to follow-up, that a relatively large amount of patients could not be included in this study because they had certain eye diseases, which impeded with the interpretation of our OCT results. So that was something to keep in mind. Nonetheless, Although the changes in retinal layer thickness were small, optical coherence tomography seems more sensitive than traditional clinical outcome measures like the EDSS and timed walking activities, as it would decrease the number of patients needed for a clinical trial significantly. Although MRI and optical coherence tomography seem promising because they're more sensitive, such measures are not of direct importance to the patient in terms of functional impairment or quality of life, while that is usually required for approval by regulatory agencies. Therefore, we looked at a way to measure balance disturbance, as this is one of the main clinical features of the spinal cord disease in ALD, and it is directly related to functional impairment in daily life. And for this, we used a force plate, which you can see in the picture on the left. And the force plate captures the movement or sway of the body, which you can see in the blue path on the right. Body sway was measured in 4 conditions: eyes closed, feet apart, eyes closed, feet together, eyes open, feet apart, and eyes open, feet together. And we compared body sway in a group of adult males to healthy controls. And in the left graph, you can see that in all 4 conditions, there was a significant difference between patients and controls. When focusing on the asymptomatic patients, which you can see in the right graph, the difference is still there, although it is a bit smaller. Besides a clear difference between groups, we also found a good correlation between body sway and the clinical severity of spinal cord disease. We don't have any follow-up data yet, but we are collecting this, and for now, it seems that perhaps body sway will be sensitive enough to detect disease in asymptomatic patients. In contrast, obviously wheelchair-dependent patients cannot be included when measuring body sway. Lastly, we also searched for what we call wet biomarkers in readily accessible materials like blood. And I will just discuss one of the biomarkers, neurofilament light, or NFL. Neurofilament light is a protein what is released into the cerebrospinal fluid and blood upon damage of neurons and astrocytes, which are cells of the nervous system. And in various diseases like ALS, NFL has been demonstrated to correlate with damage of the central nervous system. We evaluated NFL values in the adult men and women in our cohort and compared these to healthy controls. In both men and women, NFL values were significantly higher than in the control patients, and that's what you can see in the graphs. NFL values are displayed on the y-axis and the age of the patients on the x-axis. And the red squares are the patients and the blue circles are the controls. And when we looked at specific patient subgroups, we saw that there was also a difference between asymptomatic patients and controls, but not between symptomatic patients and asymptomatic patients. In men, there was also a strong correlation with clinical measures for spinal cord disease, but not in women. And during 2 years of follow-up, NFL values did not change significantly. So how should we interpret this? Because there is an important difference in the interpretation of molecular biomarkers, such as NFL, and other outcomes used for spinal cord disease in ALD. The previously discussed outcomes represent disability or accumulated spinal cord damage resulting from years of spinal cord degeneration. NFL has an estimated half-life of a number of days and therefore reflects current or recent neurodegeneration and should be considered a marker of ongoing or recent disease activity. This makes the relationship between NFL and severity of spinal cord disease not straightforward. For example, a young patient could have severe spinal cord degeneration with elevated NFL levels while not yet having any disability. And this theory is supported by our finding that NFL was elevated to a similar degree in asymptomatic patients as in symptomatic patients, suggesting that spinal cord degeneration in the asymptomatic group is already ongoing, but has not yet resulted in enough damage to cause symptoms or disability. It is likely that a certain threshold of neurodegeneration has to be reached before symptoms of spinal cord disease appear. And if this hypothesis is true, NFL could be used to monitor disease activity in pre-symptomatic patients for whom markers of disability do not apply. And this with only blood sampling and no spinal tap needed. Concluding, by the end of this talk, you are hopefully optimistic because progression of spinal cord disease can be measured, and there are several very promising alternatives. But before they can be implemented, we need longer follow-up, and the results have to be validated in external cohorts to make sure that they really represent the general ALD population. In Amsterdam, this data collection is ongoing, and we continue searching for new outcome measures. And lastly, we also have several ongoing projects with our international colleagues, of which one important project I would like to highlight in my last slide. And this is that we're working on an international ALD guideline on standards of care for ALD patients. As my colleague, Dr. Stefan Kemp, just beautifully illustrated, the number of pre-symptomatic patients in follow-up is increasing because of newborn screening. But there's currently no consensus on optimal follow-up. From what age do we start doing MRI scans? What protocols do we use for the scan? And so on. And that is why we are currently working together with 30 international ALD experts to reach consensus in areas where evidence is lacking to improve care for patients with ALD. And with financial support from Bluebird Bio, Minorix, Swan Bio, and Amsterdam UMC, and with help of Adelphi Values, a healthcare consultancy with experience in development of international guidelines, we expect to finish the guideline in the next months. So thank you very much for your attention, and I will be available for any questions in the Q&A. Thank you.